Hello, and welcome to the panel discussion section for the Short Bowel Syndrome and Intestinal Failure session of the Norton Educational Series Anniversary Edition in 2021. Just recently, you've just watched all these videos from these wonderful presenters that we have before me on the screen. Just to remind you, we have with us Dr. Adam Stein. Dr. Adam Stein gave the physician intro on short bowel syndrome and intestinal failure. He is an assistant professor of medicine at Northwestern University and specializes in the evaluation and treatment of gastrointestinal disorders that involve the small bowel, including intestinal failure, malabsorption, malnutrition, short bowel syndrome, dysmotility, gastroparesis, and the like, as well as celiac disease, cystic fibrosis, and obscure gastrointestinal bleeding. Thank you, Dr. Stein, for joining with us today, for taking time to do this panel discussion, and for that fantastic talk that you gave us that we just watched. To talk a little bit about the surgeon perspective on short bowel syndrome and intestinal failure, we have with us today Dr. David Mercer. Dr. Mercer is a surgeon and the director of the Intestinal Rehabilitation Program at the University of Nebraska. He is originally from Canada, but came to Nebraska to be trained as a liver and intestinal transplant surgeon. He developed a love for intestinal rehabilitation during his training and has become the main focus of his clinical career. He leads a team in Nebraska that works with people of all ages with all stages of intestinal failure and short bowel syndrome. Thank you, Dr. Mercer, for joining with us here today. And to round out our discussion, we have two valuable patient perspectives, two very close friends of IFFGD. Swapna Kakani is no stranger to IFFGD and the short bowel syndrome world, and has been a patient advocate, a speaker for rare diseases on many platforms, and really and truly embraces her journeys from childhood, from infanthood, actually, which you just heard about in her story. And she's here to join in on this discussion on what it's like to live with short bowel syndrome as an infant all the way into adulthood. And then also John, who is a dear friend of IFFGD and has been on many panels with us, has been a patient advocate with industry on the Hill, and in many ways been a sort of a voice for those with multiple comorbid conditions, which include intestinal failure, gastroparesis, and many other GI conditions that sort of interrelate with those conditions. And so we're really grateful to have these four with us to sort of expand the discussion and talk a little bit more about what we heard on those videos. And so right now I'm going to turn off my camera so you can see these great people and you will hear my voice as I ask some questions. But really and truly, this discussion is for the four of you guys. So let me just kick things off to talk a little bit about, let's start with short bowel syndrome. And, you know, with this video, when we listened to Swapna's story, she was born with short bowel syndrome. And I know that that is one of the ways that people have short bowel syndrome. They're just born with it. And then there are other people that get it from surgery or the like. So Dr. Mercer and Dr. Stein, how common is it to see an infant just born that with short bowel syndrome? Is that pretty common? Is that more common than we think?
Adam, I'll start.
Yeah.
So, you know, in the grand scheme of things across the whole country, it's really quite uncommon. And what's so funny is, despite being in this day and age, we don't really, as a community, understand how many patients there are with short bowel syndrome in the United States. You would think that would be a pretty easy thing to figure out, but it's notoriously difficult to figure out. So I can tell you, in terms of scarcity or rarity, we've been working on a project with another group of investigators where we're using some very large data sets, big, massive data sets covering most of the lives in the United States, and looking at billing codes, trying to work backwards to figure out numbers. And a very rough estimate is we think there could be as many as 25,000 adults with short bowel syndrome, and perhaps on the child side, it's maybe about 1/10 of that, so maybe somewhere in the 2,000 range. But even that, you know, those are probably the best numbers that we're going to be able to figure out in the United States, and it's a tough thing to determine. And speaking specifically to what you said about, someone like Swapna, the reality is there aren't a lot of people like Swapna. And why is that? Well, it's because if you were born with short bowel syndrome 20 years ago or 25 years ago or 30 years ago, or however long it was, many children didn't make it through their childhood, or perhaps were transplanted early and didn't successfully survive long enough from transplant. So we don't have a big cohort of grown-up children, grown-up short bowel kids, who are now in their 20s and 30s and 40s. There are some. We have, because we look after kids and adults, we have some, but that's a population that's growing now because we're all getting better at it. So we're getting more and more teens, late teens and 20s, but it's a rare thing. I don't need anything else to add.
Yeah, and I'll say that, Swapna said in her video, the care has really improved over the last couple decades. When nutrition through an IV or what we call parenteral nutrition or TPN was first started, we weren't very good at it. We would call it hyperalimentation because we would pump people full of 3-4 times the amount of calories that they needed on a daily basis. And often our treatments would cause more problems than the underlying disease process in kids and infants and even adults. And as we've gotten better at our therapies, people have survived longer and have thrived and done relatively very well. But I'll also say this, not only is our treatment improving, we've had better medications, better surgical outcomes, things like that, but we really don't have, as Dr. Mercer said, a good tracking system for people in the United States who have problems with their gastrointestinal system specific to nutrition. You would think we would, and you'd think that we would have centers identified and whatnot, but we really don't have the infrastructure as of right now to be able to tell who out there is at risk or has intestinal failure or short bowel syndrome.
So that sort of leads me into a question that I had, and that is that both of you mentioned sort of healthcare teams, right? So Dr. Stein, Dr. Mercer, and you work with a group of healthcare providers. There's a gastroenterologist, there's a surgeon, there's a nutritionalist, or whatever is in your group. I know your groups are very different in different hospital settings, but how common is that? I mean, I think that's fantastic, right? And if I remember correctly, John, you actually were a patient of Dr. Mercer's, and you are able to take advantage of that team that he has. So how common is that? Adam, listening to you, that's not very common then that there are these great centers for people with short bowel syndrome and intestinal failure?
Yeah, it really isn't. It involves a lot of investment on the medical centers, on the medical center itself, having teams of providers together, taking care of people who have intestinal failure, short bowel syndrome, things like that. It's not a small expense. My team, and I know Dr. Mercer's team, is probably even larger since he's a transplant center. We are not a transplant center at Northwestern, but my team, I have 2 dedicated dietitians, a dedicated pharmacist, a couple dedicated nurses, social worker. I have psychologists on my team. It's a big team. And relatively speaking, we do not have a lot of patients that filter through our clinic. We probably at any given time have 100, maybe 125 patients within our team, and we refer to our team as nutrition support. So it's a big investment. It's resource heavy. It requires a lot of training and expertise. This isn't something where you can just put up a shingle and say, oh, I'm going to take care of people with intestinal failure. You need dedicated training, you need mentorship, and you need experience. And if you don't have a team that has the training experience and that works together, it's really difficult to optimize patient care.
Got it. Swapna, through the years, I know that you have not had the benefit of going to a one-stop place like Northwestern. And so your parents and you really worked hard to sort of build teams Do you have any advice for the audience on if you're unable to go to Northwestern or to go and see Dr. Mercer, where would you like you don't live near Nebraska. What did you do in Atlanta, Georgia? Or I know you're in Georgia. What did you do in Georgia to advocate for yourself and build a team when there wasn't one close to you?
Yeah, I'm actually in Alabama, but that's okay.
Alabama. I'm sorry. I'm sorry. You're close to me, but not that close. Okay.
You can group the South together.
Yeah.
But yeah, so one, we were very grateful, and I am more grateful now than probably when I was a kid because I didn't recognize it, that my team was just 2 hours away and was in the state, and we do have a children's hospital close by, and I did have a pediatric surgeon that was passionate about short bowel syndrome and atresia and the etiologies that I did have. And so that got us very far, at least through my pediatric care. And then you kind of bounce off the few gems you do have in your community. And for me, I now have created a multidisciplinary care team of my own across the country. And really as an adult, that came from going to patient conferences that IFFGD hosts and other organizations host, and really seeing who are the speakers, who is getting up there and sharing the wealth of knowledge that we are taking as the standards of care, and practicing day in and day out, and then going and talking to them afterwards and trying to get their guidance. And so now some of those clinicians who I've met at conferences are either my dietitian now, or gave me at least the confidence to change home infusion companies or to recognize at which centers where they're not meeting the standard that I expect from a home infusion or home TPN program. And Dr. Stein's very correct that it takes a very special team model to make this and to make an intestinal failure team work. And I have discharged myself from home TPN teams that traditionally we would think are the best in the country, but because they're not including the patient's experience of someone who's done this for 30 plus years, I'm sorry, we have to think about this a little differently. You have to value my time in the home setting and what I do for myself to protect myself from infections. And value my voice. And so it took a long time, but now I do have a team that again is 2 hours away, but it's in a different state. But they are recognized as a home nutrition support team and are led by a GI doctor. And I'll also say a team that's led by a GI doctor is different than a team led by a surgeon, but both have very valuable insights. But then my surgeon is in a different state and my dietitian is in a different state. My primary care is local. And so it does require the side effect of that is it requires the patient to be that center coordinator. And that's a lot of work, and it has become almost a full-time job. I'm okay and I feel okay doing that, but that doesn't mean everyone is okay doing that. And I feel strongly that my outcomes have been correlated to my ability to do that or not. But really starting from those gems that you have found and really taking the time and efforts to listen to these kind of conferences, both in person and virtually, and harping on the excellent clinicians that do get invited to speak.
That makes sense. I'm so glad that you're able to find some gems from IFFGD's meetings. For those of you at home who maybe are unable to attend, the other thing that you can do is most organizations like IFFGD and OLI Foundation, we do put our agendas online on our websites, and you can definitely go and check it out and see who the speakers are, read abstracts often, or even watch videos. And IFFGD records every video, and we keep it on our YouTube. And so then you can learn as well. And always feel free to reach out to us at IFFGD if you need some help finding teams. John, I understand that while you do work with Dr. Mercer's team as your surgeon, and he's probably the beginning, you are in Pennsylvania. So that's not anywhere close to Nebraska, if I remember my geography correctly. So how does that work for you?
So just to clarify for a second, I went to see Dr. Mercer and the wonderful team in Nebraska for a second opinion, but I get all of my care here in Pittsburgh. Although I do credit his team with giving me guts, for the lack of a better term, to go and find a surgeon close to me who was able to deal with some of the problems I was having. That I actually found Dr. Mercer, just like Swapna was mentioning, at a conference. And then I was able to go. I flew into Nebraska. I was there for like 3 days or so, just to kind of get a second opinion. But all of my care now is in Pittsburgh, and as Swapna had mentioned too, I've been working very hard to put together a great team around me that can kind of support me where I'm at right now. I think one of the important parts that didn't come up yet, I know I mentioned it, and it had been mentioned a couple talks, was the importance of including mental health in your team as well. These conditions can be, quite debilitating, and just having that in your back pocket is always really a good thing to have. And then, for my team, most of it is actually revolving around my PCP. So about 2.5 years ago, my academic medical center, they call it the Enhanced Care Program, but basically it's a program for patients with chronic disease, who are just not being managed very well. And working with my new PCP and that team, it had been life-changing. I mean, I was in the hospital monthly to every 6 to 8 weeks if I was lucky, for a period of time. And then I'm happy to be able to say that since I've joined that team and they've adjusted my home care regimen, I've only been hospitalized 3 times in the past 2 years, and 2 of those were for surgical procedures. So I just think that kind of just shows the value in creating one of these teams. Although, as Swapna also said, it is a lot of work to kind of be navigated by the patient, which is why teams like Dr. Mercer's, I think, are in such demand right now.
Absolutely. So, one of the things I want to touch back on is we've mentioned several times here, the idea of tube feeding, right? And Dr. Stein, you talked about how that was done so incorrectly in the beginning. And I know that we've come a long way. That science has really come a long way. And I sort of understand the concept with short bowel syndrome, right? So you have less bowel to absorb nutrients. And so therefore, tube feeding might be helpful to help get those extra nutrients in, maybe higher packed calories. And intestinal failure, is that common for them to have a tube feed as well? And then sort of building on that can you explain very, very briefly, one of you gentlemen, about tube feeding and the types and what someone might expect, right? Like if they have short bowel syndrome or intestinal failure, in the doctor starts talking tube feeding, what are they talking about? What are the levels of that, and what can they expect from that? Because that's a scary thought to some people.
Sure.
I know I just asked a lot.
Yeah, let's unpack that a little bit. Couple things. Terminology is important when it comes to what's happening. No 2 people with the types of malabsorptive conditions that we're talking about are the same. Everybody's a little different in the intestinal failure world. And intestinal failure is sort of the broad umbrella when it comes to malabsorption, not getting enough liquid or hydration or nutrition in. Short bowel syndrome is one of the conditions that leads to intestinal failure, but you can have intestinal failure for other reasons. So the terminology is a little tricky, but just to clarify that. But when it comes to tube feeds really serve a couple different purposes. And they really are good in certain situations and not good in other situations. So when it comes to getting nutrition through a tube, you can put a tube in through the nose down into either the stomach or small intestine. You could put a tube into the stomach directly. You could put a tube into the stomach and then put another tube through that tube into the small intestine, or you can put a tube directly into the small intestine itself. And different situations call for different types of tubes. If a tube is not meant to be permanent, putting it through the nose works. If your stomach doesn't work, like in John's medical situation, it's often better to put a tube into the small intestine so you can get nutrition directly into the small intestine. And then you may have a tube in the stomach, which you can pop open and drain the stomach. That's called venting. And then, not to even complicate things further, but I'm going to complicate things further. The type of nutrition that you put in through the tube, there are probably 100 different formulas you can use, and every formula is unique. And choosing the right tube feed formula it's essential. It's the difference between success and failure. If you choose the wrong tube feed formula, it can cause your condition to get worse. And if you don't recognize that right away, you can put yourself behind significantly and wind up in the hospital or have other problems. So it's important to really keep track of that and pivot to different formulas if need be. And depending on where the tube is, depending on what absorption issues you have, depending on the length of your small bowel, all those things factor into the decisions about what type of tube and what type of tube feed you have. So I know that's sort of a overview to your question, but the reality is tubes are important to get nutrition and get hydration when you can't get enough of that by mouth and when your intestine works. If your intestine doesn't work, you can't really use tube feeds. But if your intestine works and you just can't spend enough time eating and drinking, I think Swapna said you were eating like a bird. That's where tube feeds can come in, because it takes the burden of eating and drinking off of the person and places it into the tube. And you can also get nutrition and hydration while you're sleeping. So you can be very efficient when it comes to this, but it's not appropriate for everybody. This is where having a multidisciplinary team who's familiar with the different types of intestinal failure, who's familiar with the different types of tubes and tube feeds, really is paramount to set your patient up for success.
It's fantastic. That actually was great. That was fantastic. So I want to move to sort of the other end and ask a question. Dr. Mercer, you mentioned in your talk that so often an ostomy is actually the best choice for your patients. And so, and I know, for example, my brother just recently had an ostomy. He had colon cancer. And one of the, the things that you hear is a lot of people that are really scared of that. They're very devastated by the thought of it, and they're not really seeing that bright side. So when I heard you say, wow, ostomy is sometimes like the best freeing thing that can happen for somebody, can you expand on that a little bit more?
Sure. First of all, I do congratulate Adam on that, because I dumped that question on him, because that's like a full day conference. You talk about that, and I knew you had 3 minutes, so I'm like, good luck. Let's see. Do well. Okay, so the ostomy question. Well, so a lot of how we treat intestinal failure and short bowel and stuff is philosophy. And that dictates how we choose what we do. And I will say, in general terms, I'm a big believer in using every bit of intestine that you have. Okay, so often one of the first things I do when I see a new patient is I say, oh, why do you have that ostomy? Can we get rid of it? Can we hook you back up again? Is there pieces of bowel that you have that aren't working? And so the sort of the first principle for me is use as much as you can of what you have. But that having been said, and I tried to allude to this in my talk, there are instances when being hooked up isn't necessarily the best thing for an individual. And we're all comfortable with pooping. For most of us, that's what we've done all our life. It's sort of socially acceptable. It's what we used to. Even if we have to do it a little more often than normal, it's not a big deal if someone says, gee, I'd rather use the toilet, I'd rather poop. And if I have to do it 5 or 6 times a day, well, that's not the end of the world. But where it can start to become a problem is, what if, despite everything that you're doing and everything your team is doing, you're going 20 times a day, or you're going 6 times at night? And we all know that we need, we spend a lot of time on our team focusing on sleep patterns, because people need to get sleep, right? You need to get 4.5 or 5 hours of uninterrupted sleep if you can, because that's a full REM cycle. And so if you're not getting that at night because you have to poop too many times, well, then suddenly you're chronically sleep deprived. And so then people are blaming feeling crappy on, oh, I'm dehydrated or I'm malnourished. And what it is you haven't had a good night's sleep in a year. So there are instances where that it is better to say, well, you know what, if what's really limiting you is the fact that your bottom end is sore, you're having to go to the bathroom 20 times a day and wiping and all of hemorrhoids and everything that goes along with that, it could be that having an ostomy, it eliminates that and gives you some freedom so that you no longer have to be tied to wherever the nearest bathroom is. There are a whole ton of different technical reasons why ostomies can be good things for surgeons dealing with disease that's in the perianal region where maybe we need to let that area settle down. We don't want poop going past it because of infectious risks and fistulas and stuff. But there are instances where having an ostomy really is a good thing, and it's a freeing and liberating thing. And it behooves your team and the professionals you have to spend the time to get you comfortable with that idea, to explain what it is, and to let you know that it's really doesn't limit most of what you want to do. I tell everybody, travel what you want, do what you want. You tell us what you want to do, and we'll tell you how to get there. We're not going to sort of tell you, here's the 20 things you can no longer do. Just say what you want to do, where you want to go, and okay, we'll work it out. So.
Fantastic. Such a great reminder to everyone at home that when you go in to see your doctor, I mean, they're not miracle workers. They can't give you everything that you might ask for, but don't be afraid to ask for what you want, because all they can do is say, that's not possible, but we can do this instead. And they can really open up your options. If they don't know what's important to you, then they can't help you achieve the optimal best life that you can live. And so that's so true, Dr. Mercer, for those at home to remember to be very open and honest with all of your care team about what your goals are for your healthcare. And then, of course, a reminder to the physicians to ask those questions, right? To remember to ask people, so what is your end goal in this, and how do you feel about certain things? So that is so fantastic. And actually, one of the things that I was going to ask Swapna and John as we sort of round out our discussion is, what are some things that you wished that you had discussed early on with your healthcare team? What are some things that came up later that, man, if we had discussed this in the beginning, wow, things would have been so much better? Or maybe questions that were not asked that you wished were, or even things you wish you had said in the beginning. Some of that conversation. What is that?
I'll jump off here to start. Thinking about a recent example. So I've had a feeding tube that goes into my stomach with an extension that goes into my small intestine. I've had that for almost 10 years now. And I was getting into positions where I ended up in the hospital about every 2 to 3 months, because I would have issues where the tube that was extended into my intestine flipped and it coiled up in my stomach. And that was bad, because then my nutrition wasn't getting where it needed to go. My stomach would not empty, and I would end up just vomiting up all of the tube feed that I got in. And I go to these medical conferences, and I had heard other providers talking about this idea of, well, why don't you take 2 feeding tubes, right? One that goes right into your stomach, and then another incision to put one right into your small intestine. So I mentioned that with my doctor just this past year. And I had surgery to go to a 2-tube system in March. And I can happily say that I have not had any episodes of vomiting feed since then. And I'm having just a lot better outcome. I'm absorbing more of my nutrition. So, something that I wish I, would have mentioned sooner to my provider, because it's been a true game changer. And I know it's not right for everybody, but it has been an absolute game changer. I wish I would have asked that question to my physician sooner. It was kind of hard, because I didn't want to be like, well, I know something better than you do necessarily. I just knew of options that were out there from going to conferences and things like that. So yeah, I think that's something I wish I would have brought up sooner.
Fantastic. Yeah, so for me, it's summarizing like 3 decades, and then some of it is I've lived through the innovations that I've gotten to see in this field. But one is, really very few doctors, if any, asked me the simple question of, what is your goal? And at that age, as a kid, it's very hard to answer. And now as an adult, I very much can answer that, but it's hard to admit a goal that may be in a different line than what's traditional of what we hope to see in short bowel syndrome, which may be you have to get off TPN, or you have to only rely on oral nutrition or enteral nutrition. And again, this is how we grew up in the early 1990s, because we saw so much fear in living long with TPN because we didn't know. It was a true unknown. And so one thing is really what I now appreciate a lot more is this journey versus this milestone of trying to hit these milestones constantly. And sometimes as a child, you don't hit those milestones due to plethora of reasons outside of our control. But when it's so attached to you, and sometimes it can affect your ability to see yourself as a success versus an attachment to your self-esteem. And then I have to give props to Dr. Mercer. So I have been his patient a decade ago now, maybe. And he asked a question that no doctor had ever asked me before. And he just simply said, how many good days do you have in a week? And I never realized that I really don't have that many good days in a week. I couldn't say 7 days. And so then we started dissecting, okay, what's going on in those bad days, which then eventually led to surgery. And then now it's really, I think, just having that comfort and confidence to really vocalize my goals, and both for life as well as medically. And I think for me, especially because I am in uncharted territory. A lot of people well, most of my clinicians, they've all admitted, we don't know what we're doing with you. And they say that very kindly. They say that we're doing this, we're very responsibly taking care of myself. But in the sense that, so for example, like I'm now on tube feedings, and I no longer have vascular access after 32 years of TPN, and tube feedings are going really well. But if you think about it, how many people have treated a 32-year-old with short bowel syndrome from congenital defect post-transplant with tube feeding at 32, but has an eating behavior of a child? Nobody. I mean, I'll answer that for you. No one. And so that's where it really takes the myself with a true partnership with the clinician, and really being transparent of what's working well, being really having autonomy over I's and O's, and being really responsible of what's working and what's not, and really saying it out front and putting your foot down. And sometimes it's easy to say, but it's not always easy to do, especially when you're the patient. And when we are the patients ourselves, we let a lot of things happen to ourselves before we would advocate, and in comparison to advocating for someone else that we love. We would put our foot down much faster if it's someone else. So just always remember, like, your voice is really important for those who are listening as patients. And it is so important to be transparent, to be vocalize those goals, because it is a human-to-human interaction, and physicians only know what they know, and they can treat you better if they know what you're thinking.
And as we were sitting here, I listened to what Swapna had to say. Another thing kind of popped into my mind about this, what did I wish I discussed with my physicians more? And I think, folks who have heard me talk before probably won't be surprised that I'm switching to mental health for a second, but, telling my providers, I think I'm probably depressed with everything that's going on, and I need help. And that was a really, really hard thing to say. It's still hard to talk about. But, recognizing the fact that I was in a bad spot helped me kind of get the care that I needed on the mental health side as well as the physical side, to get to where I'm at right now. So don't be ashamed.
Completely agree. Like, only now at 32 have I admitted that I see a psychologist, and I've admitted that to my GI doctor and my surgeon. Maybe they'll watch this, and have had an open discussion and really admitted the mental toughness, or how tough some of these past months have been, and then the trauma associated with some surgeries and some procedures that then have forced us to maybe do G-tube placement through interventional radiology versus endoscopy because of associated trauma. But that took a lot for me to admit and openly say on a patient portal message to my physician. And that came because I had other clinicians surrounding me through my multidisciplinary care team that I curated over the last only couple of years, where I feel very comfortable having this honest discussion. But this is the team for the rest of my life, and so I hope it's like that. But if anyone can do that sooner, please do it. Please reach out for mental health support sooner than later.
And to build off that, it is really important to us to know that that's happening. Ideally, we would be upfront, and I think we try to be in saying that you should get that help. But it's also important, if you find a psychiatrist that you like, there is a close to 100% chance that you will be the only short bowel patient that they will ever see. And so they need help to know how they should dose you and what sorts of things are appropriate or not appropriate. And because you may go and you may genuinely need help with the medication, and the medication doesn't help you because it's just, no one's doing anything wrong. They're just not giving you enough because you're not absorbing it appropriately. And so plenty of times we've sat and people are sitting, just like John's saying, I'm depressed and it's not helping. Everything I do isn't helping. And you find out, well, gosh, you're sort of pooping out 75% of your dose. And if we just quadruple your dose, which freaks out your psychiatrist, but it doesn't scare us, then you feel much better. So it is a really important thing to, if your team doesn't already know about that, really, really bring it up to them.
Very good. Anything to add to that, or to anything that you feel that you wish patients would tell you about that maybe they're holding back on? I think they've mentioned some really great things here, but is there anything else that you would add to?
No, I think having a trusting partnership is essential, and trusting takes a while. It takes a while to build that trust and to develop a relationship. You know, it's not something where if I saw somebody in the first time in clinic, I would expect things like this to be brought up. It takes a while, and building that trusting partnership it's essential. Everybody's different. Again, everybody is going through different issues with their intestinal failure, with their mental health, all sorts of different things, and having a good relationship is important in this community. These are great things. I'm learning as much as anybody. You know, I really should be asking as a provider more about mental health, and I love how Dr. Mercer asks about sleep. Very rarely do I get into sleep in clinic unless somebody brings it up. You know, these things are important to tell your healthcare providers because we can't read minds. And if you bring it up, it's a risk, and it's uncomfortable. The worst thing we could do is ignore it. But if you have a trusting relationship with your team, when you bring things like this up, even if it takes a couple visits or a couple messages, it's great. So thank you, for being advocates, not only for yourself, but for other people out there who are experiencing similar things.
Ceciel, I also want to say, reaching out to peers like myself and John. John and I are friends outside of this panel and this conference, and John gave me advice on a recent surgery. And I learn a lot from my own peers, and especially as we get older, as Dr. Mercer said, there's fewer of us that are older, but at the same time, there are more of us that are getting older with short bowel syndrome for a long time, which is a good thing. And so kind of together, we're figuring this out as how to thrive and live live as much of a functional life as possible with the disease. And it's really ourselves who I learned the most from. I think somebody asked me, who do I go to after my doctors? It's my friends, first and foremost, because most of the time, if before I've gone through something, they may have gone through something before I did.
And on the medical side, learn a ton from the community. So if you look at some of the major trends like in pediatrics are driven by the community. So all the big tube feed companies now make blenderized feeds, right? Why do they make blenderized feeds? They make blenderized feeds because parents said, we're making our own feeds and we think they're working better. And so if you just say, oh, well, look, I'm a doctor and what do you know? And you should really be using this feed because that's what we always use. And you didn't pay attention to that, you would have missed on a major breakthrough that's really kind of changed the way we feed kids in the last 5 or 6 years, and the way we think about nutrition. So there is a lot to be gained by paying attention to the community. And I think one of the trends, the way I hope to wrap up the rest of my career, truthfully, is flipping the entire model of the way medicine is conducted to have it stem from the patients and kind of come backwards to us so that we can determine research priorities and clinical priorities and everything else, not from me telling you what you should be doing, but from you saying this is what we need. So I think that's a good trend going forwards for the community.
And I always tell other patients and patient advocates that, we bring something to the table that you can't be taught in a textbook, you can't learn from a lecture, which is, the lived experience of having chronic conditions. And there is real power, as Dr. Mercer said, about sharing that experience, because that's how, changes occur.
Absolutely. So guys, I know that we've run just a little bit over today in this panel discussion. There's so many more questions I want to ask, but I'm going to refrain, and I'm going to just tell the audience thank you for joining us, and thank you for watching this great panel discussion on short bowel syndrome and intestinal failure. Dr. Mercer and Dr. Stein, thank you for sharing your insights and your wisdom with the patient community. We really appreciate you giving of your time to really talk to these patients and to educate them and help them feel more empowered in their walk. And for Swapna and John, I thank you guys often, and I will continue to do so, for always standing up and always being willing to share with the community your lived experiences and to help encourage them to join as advocates alongside of you and IFFGD moving forward. So this has been an amazing panel, something I think that's very much needed for this growing community of patients who are finding themselves in this situation with short bowel syndrome or intestinal failure and are really scared. So thank you for your time today and for this wonderful discussion, and hopefully in a future program we'll be able to continue talking about it. So thanks guys, and have a wonderful rest of your day.
Thank you.
Thank you
for having us.
Thank you, everyone.